So I've never had a guest on as many times as I have had Dr. Elizabath Yurth. She's now here for the fourth time, and I'm really
That
genuinely,
was 4.
yeah, it's four. I'm so grateful. And I'm also in awe at how generous she is with her time, which is a true testament to how passionate she is about educating people with the latest and greatest information in medicine. And our past episodes covered osteoarthritis and joint pain, hormone therapy for women in menopause, mitochondria 101 and fatigue. And today we're going to cover the truths and myths of heart disease and cholesterol, all in the context of a woman going through menopause. And I'll have links to those past episodes so you can catch up on it in those show notes. So Dr. Yurth's bio is so incredibly long, and it always takes a really good chunk of the introduction. So this time I'm going to try to keep it short.
Shorten it down.
Dr. Yurth, she's best known as a regenerative and anti-aging doctor who's helped hundreds of women just like us and men to solve joint pain, menopause problems, inflammaging, and just get back to our balanced and energetic selves. And she's even trained in cellular medicine. In 2006, she co-founded the Boulder Longevity Institute in Boulder, Colorado. So go to boulderlongevity.com and you can read all about her background as a double board certified doctor in physical medicine and rehabilitation and anti-aging regenerative medicine and all those fellowships and academies that she's a part of. Now, Dr. Yurth is so progressive, and she's constantly educating herself in the latest medical techniques to help her patients. And I know because I have been following her for several years now, and I see all the conferences she attends and speaks at. She then educates me and hundreds of others in her monthly Q&A Zoom sessions with her Human Optimization Academy. And now me as a patient, her team at the Boulder Longevity Institute is helping me sort out my hormone therapy journey and reverse hip osteoarthritis, which I hope we can cover a little bit for you as well too. Now, it would be a total disservice if I didn't mention how impressed I am with the service and care I get from the Boulder Longevity Institute. Like really, it's thanks to telemedicine and those physician portals that she has, is that I have this great communication with her team, and my emails and requests get attended to in just like a few minutes or several hours, and the answers I get are so incredibly thorough and just so thoughtful. So I really feel that everyone truly cares about me, and there's no affiliation here. I'm just grateful for everything that Dr. Yurth has done to help support me, and especially when I had nowhere to turn. I was really skeptical of the care I was previously getting. So I trust Dr. Yurth and the team at Boulder Longevity Institute 100%, and I really feel so lucky to have found her. So thank you.
So I really appreciate you saying that, because we actually do work really hard at that. One of the things we've done is actually tried to, and a lot of these clinics just keep trying to get more and more patients, and we actually try and limit the number of patients we take in, because we've realized that, if you've got thousands of patients, you can't give them the attention. So what we've tried to focus on a little bit more is limiting sort of the number of patients we take, so we can actually give them better attention and give them, so, which I think is not what most physicians do. Everybody needs more patients, needs more money. And we sort of realized you start losing care when you have 3,000 people to take care of. So we've actually tried to limit the number of patients. We put people on waiting lists and things like that. But, so I really appreciate you saying that, because it is one of our goals, is to really make everybody feel like they're our only patient.
You feel like that. Oh, wow. Yeah, that's makes sense now. I'm really lucky I slipped in. I, I
Yeah, and we
think.
appreciate you as a patient too. It's always good to have really smart patients in it.
Oh, thank you. We're like a perfect match. I'm really grateful. So this is just a love fest. My oxytocin is totally rising right now. So this is so cool. So before we jump in, I know I really always want to include this fancy disclaimer that we have to read, that all the information, the content and material of this interview is for informational purposes only, and it's not intended to serve as a substitute for the consultation, diagnosis, and or medical treatment of a qualified physician or healthcare provider. Dr. Yurth will not be answering questions related to your specific medical care or personal medical decisions. You got to go and become a patient like me. So now, without further ado, let's talk about heart disease. It's really an important important topic that we have to cover. So welcome, Dr. Yurth.
Thank you.
Now, I want to cover everything that you taught me about cholesterol and heart disease, and I'm always learning, and I'm just scratching the surface. So I interviewed my first cardiologist earlier this year who really confused me. And I found him from a trusted resource, but what I learned in the interview really frightened me. So I shared this episode with you, and you, let's just say you had your opinions, and I appreciate you actually listened to it and then responded to me immediately, and I was pretty blown away, and we, by what you said, and we just have to kind of debunk that episode too, and I would like to share some parts of that conversation that we had, and how you educated me on that, and what to really focus on when it comes to heart disease, which, by the way, is the number one killer of both men and women in the world. But it seems like the women who I'm in my circles, or at least are not so concerned about having a heart attack or stroke. It's more worried about cancer or
Cancer, breast
Alzheimer's,
cancer,
or
right? That's,
even
so you
COVID,
always hear, right, is, the minute I talk about hormones with women, for instance, the first thing that they ask is, well, I've heard they cause breast cancer. I heard they cause cancer. And never do they say, well, what about heart? Are they going to help my heart? And that's never the first question. In fact, it's never even on the list. So it is interesting. And you have to remember that this is, the number one killer of women. And, more than every cancer combined, lung cancer, colon cancer, breast cancer, ovarian cancer, all those cancers combined still do not mount to the same number of deaths of women from cardiovascular disease or debilitating strokes, where women are left really debilitated. And it's really as you get into your perimenopausal and menopausal years that those risks really become dramatically increased. So, it is funny that we don't really think about that. Like, we are really terrified of getting cancer. And
yeah,
most of us are not terrified of getting heart disease for some reason.
it doesn't make any sense. Yeah,
It doesn't make any sense, right?
when I learned those numbers too, I was really shocked, I'm just trying to figure out what it is. I even heard some doctors talk about breast cancer, who are breast cancer specialists, and they would say, hey, the women who get breast cancer are more likely to die from a heart attack or a stroke or heart disease rather than the actual cancer itself, because the success rates of treating it is quite high. But I just, I used to be one of those too, until I learned the numbers. And I thought, well, I don't know, you have this, maybe we see on media in terms of the classic man who's having a heart attack and pain in his left shoulder, left arm, and all these typical symptoms which women can have, but they also have different symptoms than men, and they just seem to be dissed. And we just need to bring more attention to this. So
I lost you there for a few minutes. You froze.
Really?
Yeah.
What part?
You're, it was about a minute ago. It just, you froze.
Okay. Oh my gosh. Well, you got froze a lot. Okay. So yeah, no, it's just, I was just wondering, it was just speaking about, trying to figure out why this is, but why do you think, women need to pay attention to their heart health? But sometimes even now I'm thinking, well, until Lisa Marie Presley actually died, and that was, I think it was earlier this year, she was only in her 50s, right? And I think she brought a lot of attention to that.
Which is interesting because it really is actually right around perimenopause. So 40s, 50s, that women's heart risk does mount considerably. So it really is, that's about the phase where you see a lot of women, because it's kind of as hormones are dropping. It's actually why it's kind of important. Lots of times women don't think about hormone replacement until further along the road, right? And, your hormones have dropped, and, now you're feeling pretty crappy and you've gained weight. And so women start thinking about hormone replacement when actually, honestly, the highest risk time for both bone loss, increased cardiovascular risk is at perimenopause. It's when the hormones are really actually dropping. And what we found is you can be most preventative, most proactive for cardiovascular disease if you actually start replacing hormones at an earlier age. So things like progesterone start dropping in the 30s. And I think we forget progesterone is really, really critical to help atherosclerosis. So, I think that's one of the things we really need to start forward thinking and looking at hormones at younger age, sometimes before you're potentially even that symptomatic from that. You need to be aware, hey, my hormones are probably dropping. Should I get them checked and see that I keep them optimal? A great study out of Stanford that showed that the earlier women started hormones, the lower their cardiovascular risk. It's still helpful to start later, but not as helpful as if you started earlier. So, but doctors don't ever talk to women about heart disease. They don't ever talk to women about hormones. They do talk to them about, cervical cancer. You get your mammograms regularly, get your, your pap smears regularly, but they don't really talk about them. How am I going to screen for cardiovascular disease?
So
I don't think my doctors have ever mentioned that. Have yours? I mean,
no, no. And it was in my 40s that my doctor said, "Oh, your cholesterol is really high. Like technically I should be giving you statins," but he knew me and he's like, "Just
right.
seems so wrong." And I'm like, "Okay, well, what is it?" And he couldn't help me, unfortunately. But yeah, it was just in those 40s. But you just said that progesterone starts to decline in your 30s, so which can, put you more at risk. So
Right.
I would say, should a woman in her 30s be testing her progesterone?
I mean, honestly, here's my opinion is that, like if I look at like my daughter who's in her 20s, late 20s, I actually had her do a Dutch test, a dried urine test to complete hormones young, because if I know how she's metabolizing her hormones at that age, I can prevent a lot of ongoing issues. And even at her young age, she already had not, optimal estrogen progesterone ratios, right? Her progesterone levels were lower. I could tell you, even my 21-year-old daughter, who's, kind of moody and, and gets a lot of PMS, a lot of those women are starting out square one with low progesterone. So if you look at her, she's very estrogen dominant, very progesterone deficient. So, so a lot of women are starting out even from square one with lower progesterone levels. And so, so my bias is it's not a bad idea to know what your hormones are at a young age. Doesn't mean you're going to necessarily treat them at that age, but you'll know what they are and then maybe following them. When you're young, doing something like a Dutch test, the dried urine test to complete hormones becomes really valuable because, things like cancer and heart disease actually start much earlier. We diagnose them, when we see them, but they're there. Breast cancer is probably present 10 years before it ever becomes apparent to us with any kind of testing. So we can look for things like abnormalities in hormone metabolism that are going to predict that risk in somebody in their 20s. So, my bias, and people aren't going to do this, but you can, self-order a Dutch test, and it's not a hard test to get because it's a urine test. You pee on a little piece of paper, right? You've done it. You pee on a little piece of paper 4 times throughout the day, and you have so much information from that that's going to be, and even things like oxidative stress, which we know are precursors to atherosclerotic heart disease. So my bias is if we could be more proactive at young ages when we're not thinking about this stuff, and none of us start thinking about this stuff until we're 50, right? And unfortunately, the game should be we start thinking about this in our 20s and we just follow it along. But it's really hard to convince people in their 20s that they should be thinking about it this way.
Yeah.
My kids are a little different. Actually, not all of them. Some of them haven't bought in. I have 5 kids. Some are bought in, some aren't. But at least they kind of have the introduction to, okay, this all plays a role, and at least it's in their head a little bit.
So if your daughter, say, or so it's not your daughter, just in general, if you have a girl who's in her 20s and she tends to be a little bit estrogen dominant and moody and, just kind of off, and you wouldn't treat her some way with something?
Yeah, I would put them on, my daughter's on progesterone, right? Both of them, my 21-year-old is on a little progesterone and my 28-year-old is on a little, 27-year-old on a little progesterone. So they are both on a little bit of progesterone because their progesterone levels are very low comparatively to their estrogen levels. And if you look, that's not, it's not good for pregnancy. If they decide they want to get pregnant at some point, it's not good for breast cancer health. It's not good for ovarian cancer health. And it's not good for cardiovascular health. So basically, we know that this estrogen dominant state that happens sometimes in women at a very young age. Any of you women who are younger, who are getting really, who are, or you women who have daughters and they are super, very PMS ridden people, like, nobody wants to be in the house when, before their periods. It's like, everybody just stays away. Everybody knows you could time the cycle of, okay, life's going to be hell for a week. Those they tend to be people who are lower in progesterone. And if you look, some of those people do wonderfully, even at a young age, in treating with a little natural progesterone. And, there's zero downsides to a little natural progesterone in these women and a lot of upsides.
Yeah, because I am thinking some of these listeners have daughters in their 20s,
Right.
including
Right.
me, and who can be a little bit moody, a little bit
Right.
anxious. I think I'm gonna pull out.
Exactly. Anxiety. Think about progesterone. Sorry, it's our Valium, right? It's a little more anxious, a little more irritable, a lot, get really bad around their periods, or a lot of symptomatic like cramping and things like that. Those women tend to be lower progesterone, and nothing's going to happen to all of a sudden raise their progesterone. It's going to just keep dropping with time.
Wow.
So yeah,
Very
so both my
interesting.
daughters take a little bit of progesterone.
Super interesting. Okay. I could totally go off on another track, but I'm going to try to keep with the heart thing now. And what that whole point was, yeah, as well, they're protecting themselves in their
Right.
20s.
Over the long term. So
Yeah.
starting this protection early. And it's such a hard thing to get young people to think proactively to their health, right? It's just not in their nature. And we really have to start pushing that a little bit. If we're really going to make it impact, like all of us want to do in this kind of live forever, have these incredible health spans, be, climbing mountains at 100, we probably need to be thinking about this starting in our 20s. I mean, you and I are playing a lot of catch up. We didn't know this stuff, right? When we were in our 20s, we're playing a lot of catch up on stuff. And it's not to say that we're going to still fare better than our counterparts who aren't doing it. But think about if we would have started this when we were 25, 30, would have been different.
Yeah, I wish, but yeah, better late than never.
Right, exactly.
So let's talk about 3 myths or more if you want. It's 3 myths about heart disease that a woman in menopause should know about.
So I think, number one is what we just covered. Number one is you got to think that heart disease is one of your biggest concerns, right? And, again, number one killer of females. And, if you look at females 20 years old and older, and you really evaluate their cardiovascular risk. So, study was done looking at true cardiovascular risk. So looking at a lot of parameters, looking at coronary CT scans, 45% at the age of 20 had some evidence of cardiovascular disease. So, and then when you look at things like pregnancy, which is very, very stressful to the heart. So any women who had gestational diabetes, who had preeclampsia, who had hypertension during pregnancy, they are at a much higher risk of cardiovascular disease. So number one myth is this is not the most important thing that should be on your checkoff list, is making sure that your cardiovascular risk is low and that you're doing everything in your capacity to change that risk. So, I think number two is that we sort of, I think, start looking at blood pressure. A lot of you go into your doctor and they go, oh, your blood pressure is fine. It's 130/85, right? And that's really not fine. So one of the first signs that we're starting to get atherosclerotic heart disease is blood pressure. Blood pressure is a great, simple way to monitor that. And so we have this sort of myth of the 120/80. Okay, that's standard. Nobody really starts treating blood pressure until it's 140/90. So actually, until it's actually, in my mind, pretty critical. If you look at atherosclerosis, above 115/70, we're starting to see some changes in the blood vessel lining. So in the lining, it's called the endothelial lining. It's the biggest sort of tissue in our body. It lines all of our blood vessels. When blood pressure starts climbing above that, and how many people have blood pressures above that? Quite a few. Mm-hmm. That is the first sign. And especially if it's increasing, that's why you look at people, blood pressure gets a little higher every year, a little higher for a year. Finally, it's critically high and somebody decides to treat it. So we need to start looking at that as sort of, it's a very simple, there's all these fancy tests we can do. Here's one simple test. Follow your blood pressure. If it's creeping up above 115/70, you need to be looking at the function of your arteries. And you probably are starting to develop some endothelial inflammation. So that's one simple, easy thing. And myth that normal blood pressure is normal is, a little lower is better. So I think that's probably the number two thing we should be looking at. And then number three is sort of thinking that, we always kind of think about heart disease in men, much more in women. And part of that has to do with when you look at women's underrepresentation, both in any of the medical studies. Yeah. So almost all medical studies have many more male participants than women. So when you look at participants in any of the cardiovascular literature, 70% of them are actually male and not female. So only 30% of that literature is female. So a lot of the literature is lacking in women. So when we think women are not as prone to heart disease as men, not true. When we actually look at, at women, particularly at perimenopause and menopause, the risk actually is equal, if not starting to get greater. And one of the reasons, interestingly, as men get older, so men have a higher risk, for when they're younger, and we have our hormones really protecting us, particularly estrogen and progesterone. And men lots of times don't have as much estrogen and progesterone. But as men get older, the testosterone levels start to decline. Estrogen levels start to decline further even, and then you'll see that risk even increase more. So women and men start to parallel each other as we get older. Both have a significantly increased risk, but we sort of probably as soon as we hit menopause, we start actually increasing our risk even more so than men. Men will maintain their sort of status quo with hormones a little bit longer. At least it used to be that case. Now men are dropping earlier too. So I think that those are sort of the the big things I think you've got to emphasize. And maybe then the last one is the ignorance of hormones risks outweigh benefits, because that's such a big piece of preventing cardiovascular disease. In my mind, it's so critically important that if you do not address hormones, you probably cannot address cardiovascular disease. So when doctors are just looking at cardiovascular risk and they're just looking at your lipid profile, and usually very simplistically, as you and I have talked about, they're just looking at cholesterol, LDLs, HDLs, right? And triglycerides, and they assess all the risk by that. Do they ever look at hormones as a risk? And we absolutely now know, for instance, that progesterone inhibits atherosclerosis. So we know progesterone, not progestins. Remember, there's a difference. Progestins are synthetic progesterone. That's what's in birth control pills. That's what's in a lot of different hormone replacements. So progestins are not progesterone. They do not help the heart. And in fact, they have adverse effects on the heart. So that's where some of the studies have become confused. If you look at some of the studies, it'll say, oh, hormone replacement causes cardiovascular risk. If you look at those studies, every one of them, they used progestins in the study, not progesterone. So yes, progestins do increase cancer risk, do increase cardiovascular risk. Progesterone does not. It lowers cardiovascular risk. It lowers cancer risk. So we have to make that distinction. But you absolutely have to address hormones as part of the cardiovascular picture. You cannot just look at lipid profile as sort of the end all be all. So again, progesterone is really one of the things it does is it inhibits the macrophages, which will become what are called foam cells and start atherosclerotic plaque. And progesterone will actually inhibit that. So progesterone has become very, very important. And then so does estrogen. And it works a little bit differently in keeping cardiac function, viable and protecting the heart as well. So I think that anybody who's not assessing hormones and who's not paying attention to those, that's going to be an issue. And I'll preface that with, I had a patient recently who had a myocardial infarction. So she came to me because she had a heart attack. Her doctor's like, don't really know why you had this. Your lipid profile looks perfect. She had no family history. She was 58 years old, super athletic, like probably that may have been one of her risks. She exercised perhaps a little too much, but and so she came to me saying, okay, what can I do? Where is my risk coming from? And when you looked, the likely scenario was she had zero hormones. I mean, she had no measurable estrogen, no measurable progesterone, no measurable testosterone. And that was probably her big risk factor.
Yeah, she was crazy to think she was quite athletic and
right. She had zero risk factors, and the doctors were all like, we don't really know what caused this, and we just don't have an answer. And she was like, I'm terrified now. Does she, what does she do? She has no answer to why she had this heart attack. And they put her on statin drugs. Just because you put everybody on statin drug once they've had a heart attack, it doesn't matter if it's going to help them or not. And her cholesterol levels arguably then they were already on the lower end. They actually went even lower, which even further impacts hormones, because we need cholesterol to make hormones. So once you start dropping cholesterol levels below 140 and your cardiologists are all happy, you've actually impacted hormones and now increased your cardiovascular risk. So, so that's where these kind of misconceptions of, this is all a lipid-based disease. It's not.
Let's talk a little bit about the cholesterol that you mentioned, because my next question is, what are cardiologists not telling their menopausal patients about heart disease? And you mentioned, well, they're not talking about hormones. That's probably one. And now the cholesterol point, they're not telling them what the optimal levels are. And I've learned from you and from, thanks to Dr. Diane Goodnow, who you introduced me to, and even Dr. Jack Wolfson, they've all been talking about different total cholesterol levels, right, as well as ratios and things like that. So what are cardiologists not really educating us in terms of cholesterol?
when you guys get your lipid profile done by your primary care doctor or even your cardiologist, they typically look at the total cholesterol and then what's called an LDL-C, which is calculated LDLs, and then HDLs, and then triglycerides. And they basically want you to see nice high HDLs, nice low LDLs, and ideally they like to see a cholesterol level probably under 180. Probably one of the biggest cholesterol studies that was ever done came out in 2019, where they looked at 13 million people and risks of death of anything, including actually an accident, walking off a cliff. And between 200 and 250, so the curve went like this, where between 200 and 250, that was at the very bottom. Those people had the lowest risk of dying of any disease, including accidents.
Wow.
Largely because when our cholesterols get lower, our neuromuscular function becomes less active. And so we are more likely to lose balance, things like that. So we fall more easily, trip more easily, do things like that. So 200 to 250 appear to be the least likelihood of dying of anything, including cardiovascular disease. It started to kind of creep up from there. When you start to get to levels like what the cardiologists are like, ooh, you have a great cholesterol, you have a cholesterol of 140, your the increased risk of death went about twofold. So we are really, unfortunately, when you're looking at this picture, they're just looking too simplistically. So what we have to now is pull apart, okay, is too high cholesterol a problem? Maybe, maybe not. It depends on what makes up the cholesterol, right? So we used to always say HDLs are good, LDLs are bad, have high HDLs, low LDLs, and all is well. What we now know is that's way too simplistic, and that there are actually bad HDLs. So there are small HDLs, not nice, they're all not all large and fluffy and good. And then we have these smaller and then we have these larger LDLs that are actually good. So what we really have to look at is all of the small, dense, dangerous particles. And I have a simple mind, so I like to think about cholesterol just like the big fluffy particles are like beach balls. If I throw a beach ball against my wall, I can do that all day long. It doesn't do anything. If I have small, dense particles, those are like BBs. If I shoot BBs at my wall pretty fast, I start to see damage. So basically, we know that we have to look at the small particles. So the better way of looking at this, which more and more cardiologists are getting on board with, but not all, is what's called apolipoprotein B, or APO B. And APO B is probably, so it is the measure of all of the really small, dense, dangerous particles. And then apolipoprotein A is the good protective. So we like to see a nice low APO B and a nice high APO A, okay? And that ratio of B to A should be less than 0.6. So we really want to see that ratio really skewed to high. So if I put somebody, for instance, on a statin drug, it doesn't just address their APO Bs. You'll see both come down. And sometimes, in fact, you'll see the APO As come down more preferentially than the APO Bs. So I lots of times will see people's ratios worsen on a statin drug, and you have to know that. Not always, but you have to know that. So if your doctor's not measuring APO Bs and APO As, they don't really have a clear understanding of your true risk. So you can have a cholesterol of 300 if you've got an APO B of 80 and an APO A of 180. You're in good shape, right? So basically, we have to look a little deeper when we're looking at the type of cholesterol. So that's something that you have to kind of know the answer to. Now, the next thing you have to know is, so we know that triglycerides are bad. And I think triglycerides get under treated by cardiologists, honestly. I like to see triglycerides in the under 100 range, probably closer to 70. Now, when triglycerides can get too low too. If you have somebody who's really overtrained, these kind of low energy states, you'll see triglycerides get down into the 40s. That's not a good thing either. But once you start getting above 70, particularly if you have a low good cholesterol, the low APO As, then you actually are increasing cardiovascular risk. And triglycerides are very modifiable. Typically a high triglyceride to me is somebody who is probably not eating in a healthy fashion, right? They're eating too many carbs. They have a higher sugar intake, or they're drinking alcohol. Alcohol is really, really, really bad for our triglycerides. So, so somebody who's drinking, 3 drinks a week will have higher triglycerides. There's no safe amount of alcohol. And I know nobody wants to hear that, but there's zero safe amount of alcohol. So, if you drink, you need to do it infrequently. You do it as a celebration and have a glass of wine because, you're celebrating events with family, things like that. I understand that there's people who, that's just too much of a part of the culture. And I'm not going to say nobody should drink anything, but I've stopped drinking completely for that very reason. There's just zero benefits to it, and I can do without it. I can toast something else, with my family. It's okay. Hard, I know, for a lot of people who this is more in their culture to drink. It's funny, like, you're in Europe. When I'm lecturing in Europe and I go out to dinner, everybody drinks wine. I mean, and these are these high-end longevity doctors. Everybody's drinking wine. It's just a part of the culture.
Yeah.
So I think if you're doing that, you have to think small amounts, right? Teeny tiny amounts. So drinking alcohol will raise that triglyceride ratio. When you look at triglycerides, those are an independent risk factor. You can have great looking cholesterol. Everything's perfect. If you have high triglycerides, that's an independent risk factor. So you need to look at that I like to look at sort of the triglyceride to APO A ratio. And I want to see that ratio, or triglyceride to HDLs. If your doctor's just measuring the regular panel, you can get a lot just from triglyceride to HDL ratio. And that should be, less than 1.2. So the triglyceride to HDL ratio should be less than 1.2. Above that, your risk is increasing. And then, so that's when you're looking at, we want a higher cholesterol, but we want it not in the APO Bs. We want it in the APO As. And there's things we can do. HIIT exercise, short burst exercise, raises APO As, lowers APO Bs. Long endurance, those of you who really love your long endurance exercise, your marathon runners, all respect. I used to do tons of marathon running. I don't do it anymore because I realized it probably was not the best thing for my health. So, but again, should nobody marathon run? No, of course not. People love it. Do it. Exercise is good for you, but understand that those are inflammatory. When you're doing these long endurance exercises, it's inflammatory, and it will actually raise the APO Bs and lower the APO A. So HIIT training is one of the ways to sort of change that ratio versus long endurance training, so if I see somebody who's really off in that ratio, and, I'm at Boulder, Colorado, I have a lot of very high level endurance athletes, you try and get them at least trending a little bit more to at least some good short burst exercise, some good, HIIT training, because that's going to change that ratio. And then there's dietary changes you can make, really good healthy fats, your avocado oils and olive oils, can help change those ratios. We use a supplement called citronol, LNA, which is a polyphenol citronol, a little low dose leucine, and a little low dose nicotinic acid. And that also works really well to bring down the bads and up the goods. So we can control, instead of just blankly lowering cholesterol, we can control that. So there's a lot of supplements that are really beneficial in that realm. Low dose niacin can be really helpful there. I don't think you need high dose that can affect glucose.
The niacin, you mean it's a flushing, not the non-flushing.
Right. The flushing niacin, right. And that can be really helpful to lower triglycerides and to help that ratio. You have to be a little cautious because in some people that higher dose niacin can cause some increase in glucose, and maybe a little more prone to insulin resistance depending on the patient. So you have to keep an eye on that in somebody who have on niacin. So you have to be a little careful with, there's certain people who will do very well with niacin and certain people who will not. But probably we can very well get away with a little lower dose niacin than what we've been thinking you actually need. So like a lot of things, maybe a little bit is just as good as a lot. And we're kind of learning, we're getting a little bit more into that realm, that there's a lot of things, supplements and things like that we've realizing, maybe a little bit actually works as well and has less side effects and risks than more. And my feeling is, so what we've been doing with this, mixture of this, it's a very low dose nicotinic acid. And yes, it works very well combined with these other two things, a low dose leucine and a low dose of citronol. So there's kind of workarounds on using niacin even in somebody who doesn't react well in terms of their glucose burden. And then other things I think your cardiologist doesn't look at when we are assessing risk is the inflammatory pieces, right? So most of us will look at what's called, you guys are all in this big longevity world and you listen to Zora and you talk, so, but it's looking at things like your highly sensitive C-reactive protein. So not just C-reactive protein, but what's called highly sensitive or cardiac C-reactive protein. That needs to be low. HSCRP, right?
Blood work you do.
Right. And that's just, can be ordered standard blood test. Things like Boston Heart, or we use Vibrant Labs. A lot of those will actually give all of these markers to you. And you have to look at that inflammatory piece. If that's up above 1, something is going on with a little more inflammation in the blood vessels, right? Something is affecting that vascular structure. And it might have nothing to do with your cholesterol. It might simply be that there's something else going on with your immune system, something else that's kind of created a little low-grade inflammation, but it's affecting the blood vessels. It's affecting the lining of your blood vessels. So let's back up, because when we think about atherosclerosis, coronary artery disease, remember all of our blood vessels are lined with a really thin little protein. It's called the glycocalyx, right? And the glycocalyx, if you look at it, it's very cool. It looks almost like little, fingers on inside the blood vessels that move blood along. So the first thing that happens before you get any damage to blood vessels is you have to destroy that glycocalyx lining. And so that glycocalyx can be damaged by lots of things. Viruses will damage it. Stress will damage it. Bad cholesterol will damage it. There's lots of things that damage it. First sign that glycocalyx is being damaged, watch your blood pressure. If it's going up, you're getting glycocalyx damage. COVID was a big player to damage glycocalyx. We saw really significant changes in cardiovascular parameters in people post-COVID. So, so anybody who had really bad COVID or has had it multiple times potentially has more damage to that glycocalyx lining. Once that glycocalyx is damaged, then we start, and you combine that with a low-grade inflammation, then we actually start changing. We start building up plaque. We start changing the cholesterol, so it actually starts damaging the blood vessels. So the ways to sort of see if that's happening are a couple of other markers. One is called myeloperoxidase. Myeloperoxidase is a really cool marker because it comes from leukocytes. It comes from white blood cells, and it actually is, so when the white blood cells are sort of stressed and they turn into more inflammatory cells, they release this enzyme, myeloperoxidase. And myeloperoxidase will actually create reactive oxygen species, and that's a sign that there's damage going on to the blood vessel lining. So when you see elevated myeloperoxidase, it's one of your first signs that there is damage going on to the endothelial lining. So blood pressure goes up. Now myeloperoxidase starts creeping up, right? So we like that number below 500. It starts creeping up. So now I know I'm headed down a bad path. And my C-reactive protein starts creeping up. So that's, I don't have to do any big, huge, expensive tests on that person. I can tell you they are starting to get early atherosclerosis. Maybe very early, but they're starting to get atherosclerosis.
And that's
so if
a simple blood
test?
Myeloperoxidase.
Simple blood test. Yep, myeloperoxidase, simple blood test. Again, if you do like Boston Heart's panel or a Vibrant cardiometabolic panel, a lot of these companies, it's all just included in that, right? So you get things like myeloperoxidase.
Is it the
it's a
MPO
very important
one?
marker.
Did they
MPO.
call it MPO? Okay.
They call it MPO.
Let me
Yep.
do that one.
So yeah. So MPO.
Sorry.
And it's really volatile. So, let's say you just were sick. It will lots of times go up. There was some other, you just ran a marathon, you just worked out. It will climb, but it shouldn't stay there. One of the things I always, people like you and I who exercise a lot, so be cautious not to do your bloods within about 24 hours of hard exercise, because lots of times you'll see these markers high and you'll be like, oh my God. And it's because you just actually worked out hard, right? So you created a lot of reactive oxidative stress when we work out. Not a bad thing, but if you do blood tests, if I go work out and then 2 hours later I draw blood, my myeloperoxidase is going to be high, my C-reactive protein is going to be high, and everybody's going to be like, oh my God, what's wrong? So I really tell people, try and have 24 hours between a hard workout and getting blood drawn, because you can get a lot of alterations. These are volatile numbers.
Interesting.
So when you guys are looking at, my risks without doing, big expensive coronary scans and things like that, watch your blood pressure. Blood pressure is going up. Check some of these things. What is my myeloperoxidase? What is my highly sensitive C-reactive protein? And then the things that start becoming even more concerning are now we start seeing an increase in something called PLAC, which measures another enzyme called phospholipase A2. And this is an enzyme that breaks down oxidized LDL and promotes, so it's actually allowing the oxidized LDLs to actually get into the blood vessels now. And so when those levels are high, that's the next thing that happens. I know that person I'm getting even more concerned about. They probably now are further down that road of atherosclerotic plaque formation, right? So myeloperoxidase went up first, C-reactive protein. Now I see PLAC levels go up again. That's all sort of can be easily measured on a regular just cardiometabolic blood test. One simple blood test. So you can look at the PLAC, also known as lipase or phospholipase A2. And that gives you another piece. And then last thing is look at oxidized LDL levels. So LDL, even small dense LDL, becomes problematic when it becomes oxidized and then broken down by the phospholipase A2. So if I see high oxidized LDLs and a high phospholipase A2, that person's in trouble, right? And that's where I might say we should go on and, really get further definitive testing on what's going on with you. So I think that there's so much we can learn by just a simple blood test that doctors aren't doing, and
Crazy.
it's
It
crazy.
is, it's a simple thing. Yeah. And honestly, I hope people are taking notes and writing this all down, because these are such good tests. You had me do them as well. I could get them in Europe quite easily. It's not like it was anything
Right.
crazy or weird.
Right.
So it is something I just shocked at. If you're a cardiologist, how do you not know these things? What's going on? Why don't they tell us these things?
I think because they're, so as in all medicine, we're not proactive, we're reactive. So number one, you don't go to your cardiologist unless something's wrong, right? So you don't go to cardiologist or no one sends you to the cardiologist until you have chest pain or shortness of breath or your exercise tolerance is really bad, right? So then their next step is, okay, they'll look at your lipid panel and, if it's off, they'll put you on a statin drug. But the next step really is then to take you to a coronary angiogram, because that's a nice test for cardiologists to make a whole lot of money off of. So basically inject a little dye into your blood vessels and see what the blood flow is to your heart, right? So the reactive piece is nobody gets a cardiovascular evaluation until they have symptomatology. And then the next step is to go to invasive technology to show that that person has significant disease, which then takes you to doing a stent. So now I have problems on my angiogram. I've got a closed up blood vessel. If it's bad enough, they take me right to the lab and they put a stent in that blood vessel. Again, nobody paying attention to why this started in the first place, right? Let's put a stent in, all's well. Well, not, because this person still has active inflammatory stuff going on. So now you get inflammation around that stent and the stent clots off and there's all these other issues that go on. And now you do another angiogram and another stent. And then finally you do a bypass surgery. That's the way medicine works, right? Instead of being proactive to assuming all of us potentially have heart disease, right? Especially, my blood pressure is going up, simple things like that. But how many of you guys, your blood pressure went up and you went to your regular family doctor and they put you on a blood pressure medicine? And you're like, okay, all's well, my blood pressure is lower. Well, the blood pressure is lower because you're on something that's actually, yes, lowered the blood pressure, but is that necessarily now treated the underlying cause of that in the first place, which was that you were probably starting to develop some endothelial dysfunction in the blood vessel wall that was creating that. So this is just the medicine, our proactive medicine versus reactive medicine. And I'm not gonna say there's no need for some people maybe to get stents or bypass surgeries. Sometimes it is going to be life-saving if things have gotten that far gone. The problem is we really need to be able to prevent people from getting there. And that's not the way the medical system is designed or the cardiologists are designed, right?
Yeah,
it should be within the care of the primary cares, but primary cares, unfortunately, are busy. You don't have time to do all this. They don't have time to measure all these things, discuss them with you. So and when Zora said, if you guys are not taking notes, we actually put together a Labs 101 course that you guys can go to, and Zora can give you the link to that. But the Labs 101 course has a whole thing on looking at the cardiovascular panel, what tests you should know and what they mean. So you guys can go back and reference that, so you can actually look at this yourself and say, oh gosh, I need to be nervous. Right.
Oh, perfect. I'll have that in the show notes. Of course, I forgot about that course. It is one of the first things I was looking at when I first discovered you.
Yeah, and it's great. So we will teach you guys how to look at your hormones, how to look at the cardiometabolic panel, since your doctor might not know how to do it. And then the question is, okay, well, now when I see these things off, now what is my next step? And that's where I'll take people to. You and I have discussed the Clearly scan. And Clearly is a pretty cool technology, guys. It's and I don't know if it's available to you in Europe. Did you know?
Not yet. I tried, looked for it, and no, it's not here yet. Not yet, but I'm in touch with them, and they said when I'm in the US to go and do it.
Yeah. So Clearly is a very cool test, because lots of times what people do, so what your primary care doc might do, if they're forward thinking enough, is send you then for a coronary calcium score. Okay.
Mhm.
So they do a coronary calcium score on you, and then your coronary calcium score comes back 0. And they're like, well, you're good. So treat your high blood pressure. We'll get you on a statin drug. Your coronary calcium score is 0. You're good to go. And that woman I was just talking about, who had the heart attack, she had a coronary calcium score. It was 0. So, they did a coronary calcium score. It was 0.
Crazy.
So we took her to this Clearly scan. What Clearly is it's basically a coronary CT, but it uses an artificial intelligence algorithm to be able to really discern different types of plaque. So coronary calcium score can only see calcium, which is what we call calcified plaque. And arguably calcified plaque is not going to be the thing that kills you. So a high coronary calcium score may not even be a problem for you. It's actually soft plaque, this type of plaque that actually can break off and go into the little blood vessels that more often kills people. So with this AI algorithm using this coronary CT, you can actually discern the type of plaque, where it is exactly, the type it is. It's whether it's a high risk type of plaque to actually go on and give you problems, or whether it's a low risk type of plaque that we don't really have to worry about. And then when you look at that, we can really stage. So by doing this Clearly scan, now I really know my patient's risk factor. And in fact, this patient Linda, who had the negative calcium score and had a coronary, we did a Clearly scan on her. She had stage 3 plaque disease. She had, she was, you could predict she would have had a heart attack. Now, why was that in somebody who had normal lipid levels? Probably because of other things going on, including her hormones being off. So it's a really nice test to be able to say, with definitive certain, what is my risk? And you can really see now too, if I follow that, I can see if I'm making headway with what my treatment approaches was, right?
Mm-hmm.
So, we get her hormones all optimized. We make sure her cholesterol levels are all optimized. We do everything. Am I changing her disease, or is there something I'm overlooking? Well, now I can repeat the Clearly, because it will now show me very definitively whether I've changed the type of plaque from a high risk plaque to a low risk plaque, right?
So you can change the plaque?
So you can change the plaque. You can basically, what you really want to do is turn non-calcified soft plaque into calcified hard plaque. Calcified hard plaque actually is rarely an issue. Every now and then it can build up enough that it creates stenosis, but it tends to not be. It tends to be, it breaks off and goes to a very small blood vessel. So it's very rare that artery gets narrowed by hard plaque. So what you really want to do is turn soft plaque into calcified plaque, and then you can reverse calcified plaque too. So using things like, so we actually now have, significant data showing high dose K2 can reverse hard plaque. So
vitamin K2?
Vitamin K2. So at a higher dose. And then there's some medications too that for instance, some like semaglutide, which you guys are all familiar with, Ozempic, for its weight loss purposes, actually really, really good for helping plaque. So, we can use it for cardiovascular disease as well, and it has some huge benefits. Some of the other diabetes drugs too, like Jardiance, which is an SGLT inhibitor. So it's basically a glucose transport inhibitor. And it has huge evidence to support its ability to lower or to reduce atherosclerotic burden, even hard calcified plaque. And cardiologists will tell you that you can't. Look at the studies. I mean, there's ample studies that show you can. Also, colchicine, low-dose colchicine, a drug we use for gout, at a very low dose, reverses plaque. So there's lots of options. So my goal is always, get this patient under control, stop the formation of the soft plaque, turn it into calcified plaque, and then really work on getting rid of the calcified plaque using, whatever means I need to get there. So a huge number of options in treating this. Once you know it's there, you have to know it's there. Now, should all of us just be getting a Clearly scan? It'd be nice. I mean, it is the perfect. You could have, again, like this woman where you might not have ever discerned she would have had this degree of disease. So if we could all get a Clearly scan on a yearly basis, that would probably be an optimal test.
Is it
kind of long? It's not cheap. I mean, it ends up being about $800. So that's the hard thing, is right. So I tend to push it more in my clients whose labs I'm just not happy with, right? I'm seeing a little bit of elevation of myeloperoxidase or LPPLA, so I can feel more secure that they're okay. But in a perfect world, and maybe the cost will come down, test has not been around that long, maybe the cost will come down, it would be a great screening test for everybody to do. We use this coronary calcium score as our screening test, and it's not a very it's not a very useful test, honestly, from that realm, because again, corneal calcium scores can be perfectly normal or abnormal and mean nothing. So
Amazing.
I want to add one more lab test that everybody needs to get, and it's called LP little a. And you and I talked about this, but LP little a, and I was dismayed because your cardiologist didn't talk about it at all as a risk. So LP little a is an inherited lipoprotein particle. And it's a very, very small, sticky type of lipoprotein, and it's really dangerous. And you can have a wonderful looking cholesterol profile and have an LP little a and drop dead of a heart attack, because it creates a sticky, dense plaque. And so it increases, if you genetically have a high LP little a, it increases your risk of having a heart attack or a stroke at a young age, like under 60, by about tenfold.
Wow.
And that progresses as you get older. There is not a treatment for it. You cannot diet your way out of it, or exercise your way out of it, or take a statin drug out of your way out of it. We have found the citronellite, leucine, nicotinic acid to lower it somewhat, but a lot of it, when you see that in people, is keeping the blood a little thinner. So you want to have those people take a baby aspirin at night. And those are people you really want to address the APO Bs and keep it nice and low, because you want to address every risk factor you can, right? So if I see an LP little a on people, that would be another person I would like to get a clearly scan on, especially as they're sort of getting older. So it's an unfortunate gene. Now, I will tell you, here in the US, there is a drug coming to market probably in 2026, fingers crossed, that actually is a genetic modifier. It actually works on turning this gene off. And it looks really successful in lowering LP little a's in people. I don't know what it'll cost. I don't know. But so there are options in the works. For now, it's something you need to know, because you need to be a little bit more cautious. You need to watch your cholesterol levels a little bit more. You need to, that those people, again, I put on baby aspirin, and maybe more, I'll use semaglutide prophylactically, preventatively in them. So, that's a number everybody should know, especially if you have a family history, like a parent who had a heart attack or a stroke, like at their 60s. Those are people you really, the likelihood of this LPP or LP little a being there is much higher. And then if you have it, check your kids, because they may have it too. And those are people then you want to start addressing things early and making sure that they stay on a really good path.
Wow. You shared so much. I mean, honestly, this is incredible, because you always are ahead of the game. And that's why you go to all these conferences, and you're not only teaching, but you're also learning. And I appreciate that so much. And you just got your finger on the pulse, and as things are changing. And that's why I love you so much. And that's why I just keep following you. I do, before I let you go, I just would love to share a little bit about the Human Optimization Academy, or I don't know if you have any of the programs or events or something else that you want to share. I just love the Human Optimization Academy. So that's the one I'm on top of it.
Yeah, I would love for, and as you know, as a member, Human Optimization, guys, it's our goal is, because you're not probably going to be able to get your doctor to do all these things, is you have to understand it yourself, and you have to kind of be able to, I'll take a little bit of control of your own health. I mean, this, or from very rarely are you going to find a doctor who's going to be able to help you with everything. And if you find a great hormone specialist, they probably don't know all of these pieces. So we're really trying to teach people to become and sense their own doctors a little bit with Human Optimization Academy, but also in a much more progressive fashion. And that my goal is, I mean, I read, every night I'm reading article after article and weeding out the good ones. And so our goal is then to share the most recent data so that you guys have access. So I filtered through some of the trash, and you're not just learning from your Instagrams, of somebody who wants to sell you the next best supplement. We're trying to teach you from the literature, sort of how physicians should learn, but don't. And I will tell you, Laura and I were just talking about this. The group of people who have joined this academy and there's a lot of doctors in it, thank God, but there's, I've got doctors and trainers, and, and they're really smart, and they ask me questions that keep me really challenged. So it's fun. We have these Q&A sessions monthly that are, will blow your mind, because people are next leveling things. It's not just these typical questions, is things you're like, oh my God, I never even thought of that. So we really try and stay on the pulse of all the newer stuff with that. And so, so join that. There is some free content on there as well, but I encourage you guys to join. And then you can see some of these courses too. Like I said, the Labs 101, I will walk you through a cardiovascular panel, so you understand, what are you looking at? What is my optimal things? So then I can pull out my cardiovascular panel and know, is this something I should be worried about or not? And if it is, then, set up a consult with us, set up, or find a doctor who can work with you on it, and go to them and say, listen, I'm concerned because of this, or get it clearly scanned. Right. So I do like so I would sort of push that. Follow me on Instagram. I'm not super verbose all the time on Instagram, but I try when there's cool articles or things to sort of post about them. So just at Dr. Yurth. And again, I'm not affiliated with selling anything. So I'm always kind of just trying to give you guys data and information and sort of learning from there. And I really appreciate you guys following people like Zora who have their, who have their finger on the pulse of this, because we've got to keep spreading this within more just our community. I work tirelessly to try and talk to doctors, and oftentimes it's on a deaf ear. So we really are going to have to take responsibility for ourselves,
Thank you. That's actually, my last question is always, what are the last words for a woman going through menopause transition now? And you kind of said that.
Yeah. Like I said, I think, a lot of us have daughters, right? And, I think that's one of the things to think about, is sort of encouraging them to start at least forward thinking a little bit, right? Start thinking about this stuff earlier, start thinking about cardiovascular disease earlier, start thinking about, what are my hormones doing earlier? Because I think we are going to be able, if we start teaching those people, our children, they're going to end up a whole lot better than we did. I'm doing a lot of damage done from things I didn't know, ways I ate. I mean, I remember when I wouldn't touch butter and ate nothing but egg whites, right? Because egg yolks were horrible. And now I'm like, well, egg yolks actually have all the choline that you need for your brain, so these are paradigm shifts. And I'm thinking about all the damage you kind of done to yourself. And so I think you got to share this with the younger generation a little bit too. So I encourage you to do that. And I encourage you to, just get the test, know the data, whether you decide to do anything with it, but know it.
Yeah. Well said. Thank you so much. Everybody gotta go find Dr. Yurth on Instagram and Facebook, her website. She's also not only Dr. Yurth on Instagram, but also follow the Boulder Longevity Institute there. And they're just so active. And I always learn something new, and then take a deeper dive with the Human Optimization Academy, which I cannot highly recommend highly enough, because it's really amazing. I promise you can ask the simple, stupid questions like me too. So don't worry. Those get answered. And so wonderful. Thank you so much, Dr. Yurth. I just, again, I can sing your praises forever and ever. I'm super grateful for everything that you do, not only for me, but for the community. Most people have been following me more than a minute, know you, and have been following you as well. But I want everybody who's new here to know you and appreciate you too.
Thank you, Zoe. I appreciate it. Have a happy holiday. And I'm going to let you have one glass of wine at Thanksgiving. That's it.
That's it. Just one. Forget about Christmas.